What we're going to talk about today is there's very confounding parameters of how do you select the crown. There's many different types of crown materials that can be selected these days, and there's a number of indications and contraindications for them. So I always disclose that I do not get financial compensation by any dental company. I have no financial interest in any dental company, and I don't know, and Dr. Grisalia will attest to this, I don't know how to digitally enhance a picture if I tried to. So I just import the picture that I took, and that's the end of it, okay? So I always start the lecture. You've never met these people, but when I have the honor of being invited to another country to try and share some ideas, I always thank the people who taught me, my mentors. And so my two mentors are prosthodontists, Dr. Capsnell, he's retired. Dr. Silkin still teaches. He directs a program in New York at New York Hospital, Queens, and I go there twice a month for teaching maxillofacial prosthetics. And I also have to thank my past students, because as an educator, I had the pleasure of teaching both Dr. Grisalia and Dr. Barrientos, and there's no better feeling for an educator than when their students, when they're doing their studies, present at a meeting and they win an award. And I was very pleased when Dr. Barrientos and Dr. Grisalia a couple of years ago won a poster competition in Chicago. And I also thank my future students. So presently, the students that are just finishing at NYU are from all over the world. So I teach at an international program at New York University College of Dentistry, as well as 2 hospitals. So this particular student here, in the upper left, he's from Cyprus. Okay, the guy next to him is from Italy. There we go. Guy next to him from India, Thailand, Italy, Spain, Ireland, Brazil, Holland, and Korea. So it's truly an international place where you'll meet friends for life. So anytime you leave your country, I always admire these students. They come to the United States. English is not their primary language for the most part, and yet they come and they learn. And it's very interesting to watch the evolution of education. And for the educators in the audience, they know when someone starts out the first month of the first year of either a DDS program or a graduate training program, it's amazing the amount of knowledge that the students learn in what I think is a short period of time. Okay. So I just want to touch on the history of all ceramic materials very briefly as an overview. So people don't like, or we're told that people don't like restorations that are not tooth-colored. So the evolution of tooth-colored single crown restorations starts with what's called a porcelain jacket. So essentially that's a feldspathic porcelain that's applied over a die in a refractory manner, and then it was a very satisfying restoration in the 60s that we can now have something that looks like a tooth, okay? And then the history traverses a number of all different, all porcelain materials. The physical properties of a porcelain jacket are not significant, yet a porcelain jacket can give good service for 10, 15, 20 years. They principally, in my opinion, survived mostly on lateral incisors where there wasn't a lot of occlusal force. And all of the early all-porcelain restorations were only meant for anterior teeth. So they were not really meant for molars, and if you tried to do one on a molar, you often met with an early catastrophe, an early failure. So it goes through from porcelain through Empress to a whole litany of recently zirconia-based ceramics which have superior physical properties. So if you see all those things and you're confused, I travel in Ireland a lot, and in Ireland the roads are small, you're driving on the wrong side of the road, and they're often labeled in both Irish and English, and in miles and in kilometers. So I will get out and my wife and I will try to figure out which direction we're going in. So when it comes to all ceramic restorations, it's easy to get confused. So here we have a patient that has a failed inlay, a composite inlay. Patient has now fractured the palatal cusp. So the question comes up, well, what could we use here? And there's a wide variety, as you know, of different materials that could be used here. But what I think is important for you to understand conceptually is this patient has margination all in enamel. So I love when I can bond to enamel because enamel is very predictable. Once we get into the genre of trying to bond all to dentin, I think things become very complex because the dentin is different on every patient. You can have affected dentin. If someone's 25 years old versus somebody who's 75 years old, there's a whole difference in how that bonding mechanism is actually going to work. So when you have this kind of situation, 20 years ago, probably most dentists would just say, I'm going to place a crown on this. There's too much tooth loss. When I take out that old composite that's there, there's not going to be much tooth left, all right? So the easy solution is a crown. A less easy solution, but something that's more conservative, is an onlay. So then it becomes a question. If you graduated dental school 30 years ago, you may like to do a gold onlay. Whereas maybe if you graduated in the last 10 years, you may be inclined to select something that's all ceramic or tooth colored, okay? And each of them work, and there's an indication and a contraindication for each. So if you look, this is a large commercial dental lab in the United States, and they tell you all different options for, you know, porcelain fused to metal, full cast restoration, zirconian, all ceramics. You can also do implant abutments. So there's a wide variety of what restoration do we want, what's best. And a lot of times it comes down to the dentist and certainly not the laboratory. The technician may not be acquainted with the patient's occlusion, etc., and you are best off by prescribing the prosthesis or the crown yourself. So when we look at these, there's also a question of, with all ceramics, what are these substances? You know, what is a wall ceram? There's a lot of names, but they basically are the same technology. So some of them can bond readily to dentin or enamel, and some of them you cannot bond readily to dentin and enamel. So if part of your eluting protocol is you want the crown to adhere chemically to the tooth, then you have to know which one am I going to select, okay? And that's what it comes down to, is your knowledge base is what's best for your patient. And I tell clinicians that have been very successful practitioners that do gold onlays, they do metal ceramic. If they're reluctant to move ahead to a different restoration and they're comfortable and their patients are happy, then honestly there's no reason to do so. And if they select a new material, they should really read up on it and make sure they have the indication, speak to the laboratory technician, do I have enough reduction, is this going to work? And finally, if anything requires bonding, in my opinion, you have to put a rubber dam on. So you have to have tooth isolation, which you do not require for conventional cementation. So if you're not used to applying a rubber dam, you don't do a lot of root canal, and now you have to put the rubber dam on to put the restoration in, this is another barrier to your confidence. So as we see here, the zirconia has, in addition to all ceramic, it can be broken down to lava, IPS Empress veneer, IPS Emax CAD. So there's differences in how can this restoration be made. Is it made in the technician's hands or is it made by the computer? So nowadays, remember, there's a lot of computer-generated restorations that are principally made on a TV screen. So I know all you guys out there love to play computer games. So you're very adept at that. When I grew up, that was not an entity for me to entertain myself with. But I find that the students of today, they love to get on a computer and then outline where is the restoration, and it's a great assistance to the laboratory technician, because that's the way of the future. The biggest name on the market is pretty much Procera. So Procera is technology that is computer-related. These restorations are made from a die that's scanned, and then you have a subframe that goes over the tooth, and then on top of that, you have veneering porcelain. And here's where you can also run into a problem with lab technology, because if the technician doesn't understand that he can't use his regular ceramic material on a Procera coping that he can on a metal ceramic coping, then we have issues of early failure. So early failure can sometimes be as simple a problem as the technician not knowing that the coefficient of thermal expansion for his metal ceramic feldspathic porcelain is not compatible with the new type of Procera or the new type of zirconia coping. So it comes down to the big question mark. What are we going to do? Where are we going to do it? So what we're going to try and do is go through an overview of where we're comfortable with using these materials. And what's the, when it comes to all ceramic restorations, some materials are not strong on their own, but in combination with bonding to tooth structure, their strength is enhanced. And strength is a very difficult word to use in dentistry, especially in prosthodontics, because it's hard to define. Because there's many different ways that we define strength. Is it compressive strength? Is it shear bond strength? Okay? What exactly are we calling strength? So we just give some basic strength numbers here. They're just numbers to give you an idea. Though M-press is 200 megapascals when you just do a fast fracture test of a bar, and zirconia is, over 1,000 megapascals, it seems like you would never consider to use M-press, except M-press can be bonded to tooth structure and zirconia can't. So what does that mean? When you have an M-press material, it can be etched and it can be bonded, and then you have very enhanced strength of the material which is on the tooth substrate. And again, remember what I talked about, I commented earlier. If you have a all-ceramic preparation and M-press, and you have a butt joint and you have enamel to bond to, that's going to be, for me, a successful restoration. And some of these materials will look very well for different applications and some will not. So if you have if you want to do a porcelain laminate veneer on two central incisors, a zirconia application is not going to be indicated. Zirconia is very white. You'd have to reduce more tooth, and then you'd have to veneer it, and you can't bond to it. So sometimes I'll have young dentists that are engaging me in conversation. They're like, I want to do zirconia veneers. And then I try to explore their knowledge base. Well, how do you bond that to the tooth? Oh, the technician says I can cement it. I said, well, you can cement it, but when it's a full crown, not when it's a porcelain laminate, okay? So here are some basic applications. We're going to go into more detail and more depth on each one of these. So inlay, onlay, crown, some of them can be used, some all ceramic restorations can be used for limited short span fixed partial dentures. I don't think there's a process in the world that would say that I would routinely make long span fixed partial dentures out of any all ceramic material. And that comes down to a basic difference in all ceramic and metal ceramic. So by definition, ceramic materials are brittle. You can't get around it. They're brittle. They will have cracks in them. When a crack propagates over enough time, then you have failure. And you can have a failure of the actual core, or you can have a failure of the veneering material. So the veneering material failure, sometimes it's just a mismatch and it's a technical error. But I have seen the core material fail, which requires, they say, great amounts of stress to the tooth. But you don't want to be the first guy on the block using any of the new novel materials because you don't want to have to explain a crown failure to a patient, especially as a young dentist. And then when it comes to cementation, adhesive cementation, when I talk about it, this means that you're going to be using bonding materials in the order of etchant, primer, and then a resin cement, okay? Anything that's conventional cement, it can be a resin cement, but you're not using all the components in the adhesive system. So in America, we pretty much use either alcohol or ethanol-based adhesive systems, but in Asia, they use materials that combine all steps in one. So there are materials called self-etching primers. Most students can be familiar with a system called Panavia. So Panavia is a resin bonding system which is different because the etchant, it is already in the one-step bonding, priming and bonding system. So whenever you're doing a procedure, please read the instructions for the material, because a lot of times you're very excited, you're going to bond in a restoration, and there are limitations to the materials, and you have to have a good understanding of what are the physical attributes of the system and how should the materials be applied. When they tell you you must apply 5 coats, that means you don't do 3, you do 5. If they tell you you have to air dry for 30 seconds, that doesn't mean 5 seconds. So a lot of times, errors that happen in clinical dentistry are a little bit the fault of the dentist because they're not familiar or they haven't read what they should know. Okay, so we're going to try and get into a decision-making tree. We've already touched on this tooth. What are we going to use to restore this tooth? We have a fractured palatal cusp. We have a DO composite. What are we going to do? And that could be a fractured amalgam. It could be a fractured anything. But when it comes to decision-making, one of the issues is, what does the patient want? Because nowadays, maybe they don't want a gold onlay. They don't want a gold restoration. Is it in the aesthetic zone? What else is involved? The advertisement. Sometimes patients are high dental IQ. They've seen an advertisement somewhere online. It's amazing what patients will print out and bring into me. I would like to have this particular kind of crown. Okay, why do you want that? It's very important. If you learn nothing else today, I urge you to have a very positive relationship with your laboratory technician. Because I don't care how good the dentist is, if your technician is not following all the protocols that they need to, you will not be successful as a dentist. Friends and peers. The decision making is, my best friend practices a mile from me. What is he using? Our peers are, is there a specialist in the area? I'm going to do a new technique. Let me call him or her and find out what that is. ROI is essentially return on investment. So if someone invests in some of these new sophisticated indirect restoration, so now you can have a computer in your office that will take a block of ceramic, it will drill it, you will not make a conventional impression, you'll make a video impression of the tooth, it will then drill up an MOD inlay, and then you'll bond the restoration in. So you have to be doing X numbers of those to have your return on investment, and sometimes it can give you a bias. So if this machine doesn't do MOD inlays well, but does MOD onlays well, you may find that you're cutting more tooth and it's not really in the patient's best interest. And then finally is the financial ability of the patient, knowledge base of the clinician, experience. Do we want tooth conservation? Is this a high-risk caries patient? If you just look at this patient's mouth, it looks like they have, not a lot of restorations. The tooth in front of it's virgin. Maybe you'll be more inclined to doing something that's more conservative. And then finally, you got to evaluate each patient's occlusion. And then you have to look in the dental literature. If it's a new type of material, what is the evidence that this material survives for a number of years? Can anybody guess what's the minimum number of years I like to see a paper on? ¿Cuántos años? Dos, tres, cuatro. How many years do you think I want? Cinco, yeah. So 5 years, if it's in the dental literature that someone's done a study of a material, and 5 years it has a high survival rate with minimal complication, that I think is a good material to try and start to use. You don't want to have a new material that has a new paper where the company is buying the advertisement in the journal and they have a 1-year study that they have a 99% success rate. Because the biggest thing that happens in the mouth is what? It's fatigue. So every time we chew and every time we swallow, those restorations come in contact. And again, if you have something that is by nature brittle, all ceramic, I don't care what kind of material it is, all ceramic restorations are brittle. And in the mouth, that's where things really get a lot of abuse. And it's a wet environment. So we know that when you have a ceramic material and there's a flaw and it gets contaminated with saliva, water, whatever, the crack is going to propagate. And when the crack propagates far enough, what happens? Failure, okay? So what we're looking for is longevity. And the way you get longevity is knowing what to use and when to use it. So the factors that pretty much play into longevity is the patient's occlusion. So every patient you should, analyze. Do they have a lot of wear on their teeth? Is this a patient who tells you, doctor, I've broken 4 fillings in the last year? So there are a few things that can tip you off that this may not be the patient that you should try an all-ceramic restoration on a molar. Now, a bicuspid is a different story, maybe, and certainly a maxillary lateral incisor. Maybe that's the best place to do an all-ceramic restoration. So you look for wear in the occlusion, and you listen to the patient, because sometimes the patient gives us what? Evidence. They tell us in an honest way. You don't directly ask them, gee, have you had problems breaking fillings or losing fillings? Because sometimes they broke the filling because the filling was undermined by caries. So you have to distinguish between a caries patient with active caries needing re-restoration versus someone who breaks things. And then we have to know the specific material that we're going to use, and that contributes to longevity. So right now in the United States, we have a crisis, laboratory technology support. This is not an industry that in the United States we have vocational schools, that we have thousands of students training to become laboratory technicians. Whereas in other countries, particularly in Japan, this is a place where it's considered a prestigious occupation. They have many technicians in training, many vocational schools training their technicians. This has implications for delivery of acceptable and safe prostheses. And what is driving, there's an outside force driving the number of technicians down, and that's automation. So the computer that's projecting this lecture on the screen is the same type of technology that can take away work from a laboratory. So in the old days, if someone was waxing and casting a crown or an inlay or an onlay, now it's going to be you touch a button, the computer integrates with a machine that then makes a restoration. There's a journal that I get in the United States. I read many journals, mostly professional journals. This is not completely a professional journal, but it's a trade journal. It's a journal for the lab technology industry, okay? And it's kind of interesting because sometimes these investigations that they do are not really scientific, but they can give us some interesting information. So a couple of years ago, they had a experiment where they sent the same impression to a bunch of different laboratories in the United States and abroad, and they wanted a crown made. And then they would rate the crown, on many different factors. And what happens is, what I call foreign means they were not fabricated in the United States, they were exported to different countries, mostly Asia in this study. So the USA average score was 4.6, and then the crowns that were not made in the United States were essentially equivalent. Though it wasn't a giant scientific study, it tells us some trends. So what I found interesting was that the most expensive crown in this particular group was rated to be the worst. So now you had a panel of experts, there was a couple of dentists and a couple of technicians. They rated these crowns, and this is what the finding is. So in the United States right now what happens is some of the laboratory activity is outsourced, principally to Asia. And doing that creates its own set of problems. So that's why prosthodontists in training usually do, as part of their curriculum, an investigation of some sort. So I was at the meeting. So every year, the International Association of Dental Research has a meeting where all the new investigators and all the old investigators get together and they present their research. And it's a fascinating organization to be a member of, and I encourage anyone who ever wants to go. Next year, it happens to be that the meeting's in Barcelona, and 2 years ago it was in New Orleans. And I was in the audience. This was not my student presenting. And Dr. Nathanson is a very highly regarded prosthodontist and dental materials expert and researcher, and his student was presenting tear strength and dimensional accuracy of elastomeric impression material. Now you'd ask yourself, this seems to be very basic. If you're familiar with polyether or polyvinyl, why would we have all that data? What was interesting is that the manufacturers did not supply this student with any of the materials. And that's when I got interested immediately, because I saw that in the abstract. I said to myself, why wouldn't the companies give the student the materials? And it ties into outsourcing the laboratory activity. What happened is the student took the material and he froze it. Okay, so he made an impression and he chilled it. And then he also heated it. And as a control, he did not subject it to any thermal conditions. So he gave a very interesting presentation, and all the changes that he reported were small and within ADA, the American Dental Association specifications, and accepted clinical parameters. What the audience didn't understand, so I spoke up and I said, can you explain why you did this? Because he presented a very interesting finding. People in the audience are giggling. Why did he do this? He did it because how do you get an impression made in New York to Asia? Okay, so it goes on an airplane. Okay, in the cargo hold of an airplane, what if it lands in Alaska and it's very cold? Or what if it refuels in Hawaii and it's very hot? So nobody had done this investigation previously, and it turns out that within the parameters of what's going on in the airline cargo hold, you could make acceptable impressions poured that would make acceptable prostheses. But it's interesting that no one had thought to do this, and what I found disturbing is that the manufacturers didn't want to know, because what if brand A did well and brand B did poorly? That would encourage dentists that are sending their material to a far-off laboratory, maybe they wouldn't want to use the material. So now we're going to try and touch on some of the influences of selection. What's one of the things that can influence how we select the material that we're going to place into the patient's mouth? And everybody here probably has an idea. If we make a crown today in 2009, should it last 1 year, 5 years, 10 years? So we all have expectations. What's the periodontal status of the patient? What's the endodontic status of the tooth? There's many different factors, but certainly occlusion is something we should evaluate carefully. Because a patient who comes in with this amount of wear on a tooth, they don't seem to me, without seeing any x-rays, they don't seem to me to be a caries patient, okay? So it looks like he has no caries in this anterior picture. And when we look down at the incisal edges, we see a fair amount of wear. So when I see this kind of wear, do I expect a patient with good perio or bad perio? What do we think? Yeah, good perio. Because if they have any kind of periodontal complication, the tooth is loose. So you won't see a lot of wear unless it's late in life when the patient developed periodontal disease after they developed the wear. So when I see this type of patient, I get a little bit concerned because they're generating a lot of occlusal forces. And enamel is the hardest substance in the body. So if a patient is wearing a lot of enamel, I'm concerned that what? That they're going to wear whatever we put in their mouth, okay? Same thing here. If we look into somebody's mouth, is this a lot of caries? Not really. It seems like there's some amalgam here, maybe a little bit of amalgam here. Looks like some kind of crown here. But this is another patient. This is the same exact patient, but they have short clinical crowns. So these kind of patients that have a lot of wear and short clinical crowns, they have usually a thing called a low Frankfurt mandibular angle. These are patients prone to generating a lot of occlusal forces. So these may not be ideal patients to do a second molar all ceramic crown of any type. The other thing that I try and teach to all my students in every program I ever teach in is that look when the patient first closes, they bite down. Then check them in protrusive. You guide them into protrusive. And most of the times, this patient's never made this movement before in their life. So you have to show them. So I just do it myself. I bring my teeth forward, show the patient. I make them go into right working. I make the patient move into right lateral, and I'm examining to see what's going on. And in a patient with a lot of wear, a lot of times when they go into protrusive, like in the protrusive picture up there, there's a protrusive interference on the last molar, okay? If there's a protrusive interference, I guarantee you there'll be a non-working interference if they go right or they go left. So this contributes into why patients wear their teeth. If they disclude, they usually have less wear. And then if you look on a cast, you know, here's a patient that has what appears to be, you know, pretty intact cusps of teeth, whereas if you look very closely, there are wear patterns on these teeth. And so at a glance, a technician sometimes doesn't see this. And again, this is a team effort. So if the technician calls you back and says, gee, doctor, I think this patient is not a candidate, you have minimal room to veneer a Procera coping or a zirconia coping, my own feeling is you'd be better off with metal ceramic. Now sometimes that ties into preparation. So before you prepare the tooth, you have to understand what is the substance of the crown that's going to go over the prepared tooth. So some preparation styles are contraindicated to all ceramic. So principally in metal ceramic, shoulder bevel or chamfer bevel, you cannot cover a bevel with ceramic. It's a contraindication, it's a sharp line angle. So that you have to understand and know because a bevel sometimes can give you more tooth structure. And that's a principle called ferrule. So if you don't have enough ferrule, I don't care what kind of crown you put on. So the minimum amount of tooth structure to retain a crown is 2 millimeters. So if you have 1 millimeter, then the tooth needs to be extruded orthodontically or you have to do crown lengthening. So understand that the biological principles of tooth preparation also play into what material you selected to create the restoration. Also, very simply, where in the mouth do we generate a lot of occlusal forces? And we all know posterior. So that's where a lot of the early all ceramic studies in vivo generated the most failures. And this is not a fault of the clinician. A lot of times clinicians in private practice drive the market because they have high demand patients that don't want gold, or they don't want silver, or they don't want metal, or who knows what they don't want. But sometimes that's actually the best restoration for them. And I try to tell patients that, because to do an all-ceramic restoration on a second molar, nobody's going to see it, and it requires a lot more tooth reduction, approximately 3 times more tooth reduction than if you do something like a gold restoration. So when we talked about it, we touched on occlusal forces and we touched on fatigue. So the best way to explain fatigue is everybody has taken a wire hanger, a coat hanger, and we can bend a coat hanger 10 times, 100 times, 300 times. Eventually what happens? It breaks. Okay, so metal is also subject to fatigue. So metal is not, completely fatigue resistant, though the property of the metal allows some elastic recovery. So you have to understand from biomaterials that you learn here in school, there are reasons that we like metal for certain indications. So we know that in the occlusal forces, we got greatest towards the posterior. Non-working contacts are most destructive because they actually give the patient a pivot point to generate more forces, and it's a function of time. So time in dentistry is our enemy, because when we deliver the crown today, the crown's going to work fine today and tomorrow. But as time goes on and the crown is subjected to force and fatigue, that's when we have our failure issues. So we touched on wear a little bit previously, and you have to be very astute to look for wear, and the only way you can pick up some of the wear is by making the patient move their jaw. So sometimes when a patient has a large malocclusion, classically a class 2, I don't understand how that class 2 patient, the number 6, is very worn. I don't understand that, because to make that patient go out that far indicates a very large, what's called envelope of function. So when we analyze patients' occlusion, you have to bring them out. It's like a puzzle. How did that wear happen? Keep bringing that jaw out. You'll be surprised sometimes, because the only way that tooth gets that amount of wear is they match up. So the antagonistic cuspid will have the same amount of wear in the same geometric fashion. So abrasion, we know that in the scheme of things, acrylic and denture teeth are on the low end. So if you have an acrylic prosthesis, a partial denture, and it's opposing a human molar, there's not going to be wear occurring on the human molar. The wear is going to occur on the acrylic or the denture teeth. Same thing kind of with the composite. So there's a hierarchy of where does the wear occur. So with human enamel, gold and amalgam are pretty much compatible. They've done a number of studies over the years that if a patient has a restoration that's gold or amalgam and it's opposing a natural tooth, there's going to be an acceptable amount of wear. Porcelains become an issue. Nowadays they have porcelains developed that have less wear. They create less wear. But what people don't understand is that when you adjust the occlusion on a crown, I don't care if it's a metal ceramic crown or an all ceramic crown, you must polish it, okay, or refire it, because if you leave a broken glaze on a crown, that will generate a phenomenal amount of wear. Because if you ever feel it just with your finger, if you take the glaze off a crown and you feel the glazed part and you feel the unglazed part, it's rough to touch. So most patients that have metal ceramic or all ceramic crowns on the anterior teeth that say have a deep bite, they're going to have a situation where they're going to wear the human enamel quite quickly. And you saw some evidence of that earlier. So what do we know about dental ceramics? Though they give us superior aesthetics and they have resistance to abrasion, they cause wear of human enamel. We've talked about brittle. They are by nature brittle materials. They're fused by heat, but they are brittle. Then remember what I talked about? Very important. So you got to polish after your occlusal adjustment. So the easiest way, and the way I promote, is you take the crown out of the mouth, you put it on the die, and that to me is the best way to polish the crown. Because it's metal ceramic, maybe it's getting a little warm to touch to your fingers, and you can stabilize it, because sometimes a student's holding it in their hand, and as they're polishing the crown, it goes flying off into space. And it gets lost or it gets damaged, etc. So I tell you, just put it back on the die, hold the die, and learn to, secure the restoration so that you don't misplace it. So here's where we talked about articulating surface. So if someone has the need for two crowns, whether they're metal ceramic, all ceramic, I talk about the articulating surface of a crown, because I'm not concerned about the buccal of a central incisor, because that is not hitting an opposing tooth surface, okay? I am worried about the palatal aspect, because that is articulating, in this case, with what? With the natural tooth. So you see that these are crowns that have been in a number of years, 8, 10, 12 years, so this kind of wear doesn't occur overnight, but it is a factor to consider, because I've seen patients, and I'm sure the faculty in the audience have seen patients where the wear is so considerable that they can't restore the opposing teeth. It's hard enough to prepare mandibular lateral incisors or central incisors. They're tiny to begin with. So if you're trying to prepare them and they've already worn considerably, I'm talking about 25% of the clinical crown height, this is a very difficult restoration to do. And this ties into what's called the philosophy of treatment, conformative versus restorative. So some people would tell you, well, no one can tell that occluding surface is metal. Okay, just like no one can tell looking at it that the occluding surface here is ceramic. But I would suggest to you that there is less wear on the opposing tooth in the same mouth, because the dentists, when they fabricated the crown, understood a wear concept. And sometimes it's also a concept with regards to tooth reduction, because I have to prepare that tooth essentially 3 times less to have metal. So if I don't want to run into the pulp or do an endodontic procedure, sometimes I try to encourage the patient to understand that we're using metal not because I'm addicted to metal, it's because it's the material of choice for your mouth. And educating the patient is a big part of being a dentist. So the higher the IQ of the patient that you're treating, I think the more success you'll have and the less dissatisfaction you'll have. And then some patients will not accept a metal restoration. And I respect that as well, as long as they understand the consequences, because after you prepare a tooth, and now the tooth has pulpitis, you can tell the patient, but I told you that if you wanted this all ceramic, or you wanted white material on the inside where nobody can see it, I didn't do it on purpose, but I can prepare the tooth, and you may in fact have pulpitis that will require treatment if it's irreversible. So again, there's been a number of studies regarding wear of opposing enamel, and we have a litany of different materials here. And essentially, what's the take-home message? Sorensen is a prosthodontist. He's a DDS PhD on the West Coast of the United States. He's presently in Oregon. He had been an educator, and he's one of the guys I trust. Though he accepts money to fund studies, if the material is good, whatever the data shows, he's going to present. So if we look through here, as we touched on before, there's some older materials, Empress, layered or cord, versus some of the new materials here, Vita Alpha, Procera. These materials are more resistant to causing wear. And this ties into, how many microns of wear do you expect in a year? And before long, the tooth opposing it may or may not need a restoration if you want to restore the occlusal anatomy of the opposing tooth. Now we get into the realm of evidence. So right now, in dentistry, we're trying to teach, before we make a treatment decision, we'd like to have some level of evidence as to why we're recommending different types of materials or a different protocol, or what are we telling the patient to have for treatment. So there's analyses of clinical trials. That's one type of evidence. So the best type of evidence is usually a prospective, randomized clinical trial, where there's 2 different crowns. Patient A comes in, they get crown A. Patient B comes in, they get crown B, and so on. There's no bias in the investigator looking and trying, crown A will work better in that mouth. So you have to be honest, and you have to do a randomized study, and then you have to perform the procedures, you have to collect the data, and you have to wait 5 years. And as usual, when you do an in vivo prosthodontic investigation, is very exacting. it requires patients to stay in the geographic area. And in America, America's a very mobile society. So patients moved away. Now, after 3 years, you're disappointed because you did 50 restorations, but you can only recall 30% or 30 of the patients. So you've lost a big part of your population, which will damage your final results. And then retrospective is the weakest kind of evidence, because as you look back, you recall your patients and you say, oh, that crown broke after a year, or X crowns broke after a year. But that is an anecdotal kind of thing, as is a case series. I did this type of implant 6 times and it worked 100% of the time. Or what's even worse is I only did 1 crown and here it is and it looks beautiful after a month. Animal studies also can give us some information, but the way an animal articulates is much different most of the time than a human. So a dog is going to have a vertical stroke, as will a cat. If you do any kind of ape studies, these are very expensive animals to house and to take care of for a number of years. Laboratory studies are the next best thing because they can give us some information, and it's essentially what we call crunch the crown. You have a crown and you subject it to different types of forces. Sometimes it's just static. You load it until the crown breaks. What is the crown sitting on? Is it sitting on a tooth mimic? Is it regular dentin? Is it a human tooth? Is it a bovine tooth? And what manner are you studying it? Are you compressing it? Are you shearing it? And then the least part of the hierarchy are the advertisements. And believe me, the business of dentistry is all about selling product. And hopefully as dentists, we don't sell products to our patients. We make informed decisions about what is best in this clinical situation. And then also word of mouth. My friend down the street is using the latest and the greatest crown, and he works for the company, so he's trying to tell as many of his friends to use the material as possible. So this is our hierarchy of evidence, and then how do we use this in clinical practice? So this is where you get a dental journal in the mail. So is this really a journal? So when you look at, volume 1, number 1, you kind of get suspicious, because this is part of what's going on in American culture today, is that the companies are marketing very slick-looking journals that look like they're legitimate, peer-reviewed journals, but they're not. They're essentially an infomercial, just like you see on TV for the latest and greatest nails or paint on nails. This is no different. And it's also based on selling, so undiagnosed and untreated smiles in your office. In my opinion, I do not project a patient need. If a patient comes in and doesn't complain about their smile, I don't say anything to them, even though their smile may not be attractive, even though maybe they have yellow teeth or chipped teeth. I do not give them a diagnosis based on my own opinion and not theirs. Okay, and that's very important, that you don't project treatment needs on someone who doesn't want treatment. Because every time you cut a tooth, there's consequences. And anyone who's been practicing for more than 10 years knows that there's a cycle of restoration and re-restoration. How long is that single crown going to last? How long is that 3-unit FPD going to last? How long is that 6-unit fixed partial denture going to last? So we know from prosthetic literature that long-span fixed partial dentures, which is anything more than 3 units, after 10 years, about 70% of them remained. So what happened to the other 30%? They were lost due to a variety of different reasons. And then this is the hierarchy of journals. So if we look, the Journal of Dental Research is in the corner in the upper left. That is the highest amount of scientific evidence that you can get. If it's published in the Journal of Dental Research, I believe it. It's very hard to fool their peer reviewer. So underneath that is the Journal of Prosthetic Dentistry, OOO, Journal of Endodontics, Journal of Perio, and then the Implant Journal. Then in the middle are American journals, the Journal of the American Dental Association, Compendium, Practical Periodontics, and Contemporary Aesthetics, okay? Then on the far right, in America, we have these journals that are really infomercial-type, advertisement-type journals. There's something to be learned from it. If there's a new material there, you may want to then do some research. Is this good? This new cement looks fabulous in this article. Maybe I should, do a lit search and see what's going on, if there's been any kind of legitimate research conducted here. And this is the kind of thing that I hate. So now we look in a journal. I don't have an axe to grind with any of the companies. I mean, here's something where they're showing a case presentation of replacing some incisors with some implants, and now they're showing us, a particular product, which is this product here. Except what makes me a little bit annoyed is that this is the exact journal, so on the page next to this article is the advertisement from the company promoting that. So that usually indicates for me editorial bias. So the company comes to the journal and says, hey, I want to take out 10 pages worth of advertisements. I'm hoping that you may get a journal submission for this particular type of product. So that's what decreases the legitimacy of the type of paper. So you may read this, you may gain some knowledge from it, but this is not the kind of evidence that I want you to understand and respect. So we're going to now go into, we've kind of given a background of what are we looking for when we select a material. Let's talk about some specific materials. So from the top, we have feldspathic porcelain. That's a classic porcelain that's melted on top of different substrates, be it metal or some type of all ceramic. Pressable ceramics are materials that are heated and then pressed into a mold, kind of like the old lost wax technique that you'd use for an inlay or an onlay. Then there are things called no-prep veneers, which is promoted by a company where you don't have to drill any tooth structure and you can make these restorations. Aluminous oxide, same thing. What is it? What's the indication? Why do we use it? The zirconia-based ceramics, and then the machinable ceramics. And the machinable ceramics, for the most part, I'm talking about in-office units, where it's a very large investment to get a computer that can then make these restorations that you then cement into the mouth. So we've talked about abrasive and brittle nature of ceramics. There's some minimal thickness requirements. And if you do not achieve them, you cannot use certain all-ceramic restorations. So then in general, what are these parameters of care? So usually you need about 1.5 to 2 millimeters occlusal clearance. And this is pretty much almost like metal ceramic. Then you need an axial reduction of 1 millimeter, which is a little bit less than a metal ceramic. And that is an advantage, because that is drilling the tooth less. Then what is the resin bond strengths? And I try and teach some basic bonding anytime I give an all-ceramic lecture. We've got to know what are the numbers when we bond porcelain to porcelain. So if a patient breaks a metal ceramic crown and it's all in the porcelain, you can make a porcelain veneer and bond it very effectively and salvage the prosthesis. We know that we can take porcelain veneers. I don't care what kind they are. They could be pressed ceramic, they could be feldspathic, and we're going to get a very good bond to enamel. Does anybody know what the enamel strength, in a shear bond strength test, classically, what's a number for enamel bonding? Okay, so I try and teach, this is a very simple mathematic progression. So very simply, we're going to go 30, 20, 10. So enamel, I just say it's around 30 so that you can remember it. It's really closer to 40. Bonding to dentin, it depends on the system, so I say 20, but it really can be 25. You can actually get a very good bond strength with different bonding materials to dentin. And then metal is around 10. So if you look in the articles, classic bond strengths of metal to dentin, to a substrate, is around, it's usually around 12, okay? And knowing these can enhance the restoration that we do, because if we bond it, we're picking up something that we don't have with conventional cementation. And that's a physical bonding of the substrate to the tooth. So feldspathic porcelain's the top of the list because it's been around the longest. Where do we use this? So they go by many different brand names. A few to throw out, I'm sure they're available in Guatemala, is Ceramco, Nuritaki, Design. They're made by big manufacturers. So same thing, minimum thickness is 0.5 millimeters if we're doing a porcelain laminate veneer. If we're doing metal ceramic and the metal's going to be veneered with the porcelain, you need 2 millimeters. It has the best color matching capabilities, in my opinion. And color matching is a whole different thing. And if you have the technician available to do a custom shade in the office, or you have the patient report to the laboratory, you try and get a match of a single central incisor with a single laminate, it's a very challenging thing to do. And the best shot that you have, in my opinion, is with feldspathic porcelain. So as we touched on, you can use it for veneers, crowns, inlays, and onlays when it's veneered on something else. So for inlays and onlays, it may or may not be veneered on a pressed ceramic. And we're going to talk about pressed ceramics as well. So abrasiveness and the brittleness with regards to the other porcelains, this is in the ballpark. This is no better or no worse. And there's significant data on its use. So if we look here, we have, from a wide variety of journals, the Journal of Adhesive Dentistry. That's not something I routinely read, but if there's some new material and I want to find out about it, that's a good resource. Journal of Dentistry is actually a European journal for general dental principles. And again, it'll have some good information for us. As a prosthodontist, if I was an orthodontist, I'd be looking at the Journal of Orthodontics. But as a prosthodontist, I'm principally looking at, the Journal of Prosthetic Dentistry or the Journal of Prosthodontics, because in that, they will have, significant findings. And Dr. Goodacre is the dean of the dental school at Loma Linda. And over his career, he's another one of those names that I trust. He does very exacting research, and he has a dedicated band of researchers and clinicians that work with him, and they give us good information. And this may be a lit review, and it was essentially clinical complications of fixed prosthodontics. Why do the prostheses fail? And they fail for a wide variety of reasons. It could be fracture, it could be decementation, it could be caries, it could be perio, but he gives us the numbers, okay? And that also helps us select things. Here's a paper from a journal that's it's in the mid-range of where evidence is, but again, sometimes you find evidence that some evidence, in my opinion, is better than none. Here's 5 years clinical experience with lucite reinforced porcelain crown system from the International Journal of Perio, and this screams at you, okay? You looked at failures, it doesn't seem like there was any. In the anterior, a few in the premolar, but if I see a failure rate of 20% of an all-ceramic system, that I don't feel is giving the patient a service. In fact, it discourages the patient, because now I always ask, if an all-ceramic crown fails, do you do another all-ceramic crown? And I did some very basic questioning at a meeting maybe 10 years ago, and my bias was that the experienced clinicians would immediately make a metal ceramic crown. They made the one that they knew worked, whereas the younger clinicians said, oh, I would make another. They changed the name of the all-ceramic crown, not know the indication, the contraindication. So they were more willing to take a risk. And in clinical practice, you don't want to take a risk, because every happy patient that you have doesn't really report they're happy with you. But the unhappy patients can create a lot of problems in your practice, because they're going to tell everybody that you're not a good dentist, etc. So the best way to avoid that is to do predictable treatment. So here we have a patient with an intact dentition, and if they're missing a tooth, there's many different options. How do we replace that tooth? Could it be an FPD, a fixed partial denture? Well, these days, I don't like to drill down virgin teeth. So in my opinion, unless someone said that I don't want to have, I'm a hemophiliac, I don't want to have surgery, I don't want to run the risk of a surgical complication, I'm going to recommend that they see a colleague, a specialist that places implants, and have them evaluate whether they're a candidate for that. And if we do restorations, this is the thing we talked about earlier, are you going to place the rubber dam? Because that's the only way you can prevent contamination. So when I say contamination, people they'll tell me, oh, Dr. Kurtz, it's wet bonding. Well, wet bonding doesn't mean saliva coating the tooth, okay? Wet bonding means that you've cleared off any debris, that you want the tooth to be moist, and then you're going to bond in your restorations, and this is the best way of doing it. And you can anesthetize the patient. They'll understand. You give them some local anesthetic, you place your rubber dam, and you can go ahead and do your restorative procedures without the patient coughing, sneezing, contaminating what I think is a very complex field, because you have dentin, you have enamel, you have conditioners, you got to rinse etch off, you got to rinse dry bonding agent. It's very stressful. It's one of the most stressful procedures you can do. This treatment is actually accomplished by a professional colleague of mine. I am not passionate about all ceramic restorations. As far as I'm concerned, they're a necessary evil, and I teach it, but I'm not one who will do a lot of elective aesthetic treatment. So most of the patients in my prosthodontic practice require multidisciplinary, comprehensive treatment, so I treat less of this type of patient. But it doesn't mean that it can't be accomplished in a beautiful manner. So now we're going to touch on a concept that when porcelain laminate veneers were first introduced, there were no preparations. And then the complications of not preparing teeth are such that you have an over-contoured tooth, there's periodontal considerations, etc. The pro is that you have enamel to bond to. The con is that you're often over-contoured. And this is a little bit of a controversial topic in the U.S. With regards to not preparing the tooth, because some patients don't want you to drill the teeth, but they want some kind of aesthetic solution. So they go, in the United States, they go by commercial names, lumineers, viveneers. And they certainly provide some level of aesthetics. There's a question to how much tooth. Some of them say that you only, if there's no reduction, we can make them as thin as 0.2 millimeters. And I don't know that that's effective because I've never seen a paper that demonstrates that that's going to give any longevity. There's a question about how does impact, if something's over-contoured, how does that impact the biological width of the tooth? Is it a negative prognosticator for the long-term periodontal health of the tooth? So excess crown contour, gingival health. If you add incisal edge to a no-prep veneer, you're actually increasing the functional surface of the tooth, which may or may not induce mobility. So if you make a tooth bigger and it now has a bigger articulating surface, a tooth that previously had half mobility may now have one mobility. And then the patients sometimes notice that. Gee, doctor, before I had this procedure done, when I tap my teeth, they didn't move. And now when I'm chewing, I feel that my teeth are moving. So unfortunately, we have this as an issue to consider. So what do we know about over-contouring and greater accumulation of plaque? So a lot of times we can look to, our periodontal colleagues, general dental colleagues, and they've examined it in an animal model and in a human model. And what they find is that, if you change the contour, sometimes you can have a negative periodontal outcome. So when you go to some of these newer materials, they have an advertisement website. In 2 to 3 visits, you can have a custom-made smile that is clinically proven to last over 20 years. Yet this is a material that I've never seen it before. How do they have this data? So this is what I call speculation. And it's completely reversible since your natural tooth structure is intact. That is a good point of that. So if a luminaire had to come off, that's terrific because you haven't really violated any of the tooth structure. But the ethics of promoting materials without the database that supports this statement is disturbing to a professional. So when you look at this, it turns out that they did have some data, and it's from a citation that's usually not allowed in peer-reviewed journals. So this was from a industry-generated journal where they quoted a clinician who happens to be a very good clinician at the University of Maryland, that he was talking about etched porcelain veneers, except he's talking about conventional prepared etched porcelain veneers. He's not talking about no prep veneers. So that's what I'm trying to get you to understand, is that when you embark upon doing a procedure in a human being's mouth, you're a doctor. You have to have some basis and some understanding of what you're doing and why. It's called treatment rationale. So presentations should not be cited as references. And certainly my presentation today should not be cited as a reference. And then here's the website that tells you all about how to make these particular restorations. And again, they invest a lot of money, and this, I'm not saying that there's no use for this. This may, in fact, there may be indications for this, but I'm not aware of them presently. But, in the future, I may be impressed by some of the results that they'll get. So right now, I thought, since we're about halfway through, if we have any questions about what's been presented, to this point, I think it's a good place to ask them, because essentially we've gone to the background information of analyzing where to use all ceramic materials And we've touched on a couple of very basic treatments, feldspathic porcelain, and we're going to now go into some of these more sophisticated all-ceramic selections and treatments. So if we have any questions, a good time to ask. No question is an invalid one.
What do you think about the pot joint ceramics crowns?
Butt joint metal ceramic. Yeah, absolutely. So very good question. I think I touch on them a little bit later. So some of the major critiques about a metal ceramic crown is that when the patient smiles, after some years, maybe you'll see a metal margin. And the patients do not like a dark line in the aesthetic zone. So one way around it is you can have a metal coping made, and you do one of two things. The metal surrounds the tooth, but does not come out on the butt joint, so that the technician then fires ceramic directly to the butt joint. And what's even more innovative is that there's a prosthodontist that did some very interesting research when he was a resident, is they made the coping, and the coping, if this is the top of the crown, is a central incisor. What he did is he made 3 types of copings. He cut it back 1 millimeter, 2 millimeter, and 3 millimeter. So 270 degrees of the coping was all metal. And then in the front, it was either 1 millimeter, 2 millimeter, or 3 millimeter was exposed dentin. And then they fired porcelain on top of that, made a crown, and then they broke them. And what was interesting is that the difference between the cutback of 1, 2, or 3, they were all equivalent. So if someone's in a very high demand aesthetic zone patient, you can make a metal ceramic butt joint crown and get very acceptable aesthetics. So that's a very good question. The more problematic issue comes up when you have a cutback metal ceramic butt joint crown, is that the porcelain there's special porcelains now, they're called shoulder porcelains. That porcelain is glazed. So now the question comes up, if you have a very shiny surface, is the cement going to stick to that? And so sometimes you can do a bonding procedure. You can use hydrofluoric acid that you use to bond in a porcelain laminate veneer. You can break the glaze just on the shoulder porcelain and then use a resin cement to bond it into place. So there's different applications, or you can use a conventional cement. What you probably don't want to do, according to most literature, the other way to break the glaze on a crown is to air particle abrade it. So if you sandblast that butt joint of a crown, the question comes up, you have now made some impact damage to the ceramic, and then long term, can that contribute to its failure? So no one really knows that the implications for that. Because certainly on a metal ceramic crown, does everybody know what air particle abrasion is? Sandblasting? So you're roughening the internal aspect of the crown because it gives what's called micromechanical retention. So even if you're going to use a conventional cement, ZOP, anybody know why I like ZOP? It's a very old cement. Yeah, it's cheap. So I'm a dentist and I'm frugal. So if I have a good tooth preparation, you can use ZOP cement and it's going to last a good amount of time. Most of the bonding cements, luting agents, they're quite expensive. So per unit that you lute them in, know when to spend money. So if you're an intelligent clinician, I will spend the money when I have to. So I'll use a particular type of crown with a particular type of luting agent or cement when I know I have to. Otherwise, I'm going to go in a more conventional route. But thank you for that question. Now we're going to get into some of the systems that weren't around 20 years ago. And pressable ceramic is a very aesthetic material. And they're pretty much made by a couple different companies. The names that are common that we may know from literature are Empress and OPC. They're different manufacturers, but they're both valuable and predictable restorative materials. So what's good about this is that when a technician who's your partner in restoring people's teeth comes up with technology that he's familiar with, he's more enthusiastic about it. So when pressable ceramics came out first, they were embraced by technicians because they knew how to do it. This is similar lab steps to making a full cast gold crown. There's nothing different. You're going to make a wax up, you're going to invest it, and then instead of casting it with a torch, they have a sophisticated machine that's going to make the crown for you. So here's what we do. You can do something like a full contour wax up. And then you go ahead and you sprue it. everybody know what a sprue is? So a sprue is the red thing that connects to the white. So the white is a wax that's being contoured to match the patient's dentition. So this is the exact shape of the tooth that you want, and now you have sprued it, and you do just like you do for a gold restoration. You're going to invest it, which means you're gonna pour in a stone essentially. So you pour in a refractory stone that now hardens, and now you can subject it to heat treatment. And this is a very sophisticated machine with a computer program that will allow the molten ceramic. So instead of having molten gold going into the mold where the wax has been eliminated, you now have ceramic being pushed in there like lava. There's a lot of volcanoes around here, so it's like lava. It flows in there. It's a thick material. So how do you get it to flow? Gold flows very well. When you heat up gold and it melts, it's like liquid. It's going to flow right into that mold. The ceramic material is thicker, it's denser, so it requires different technology and high heat, and they have a giant piston. So it gets pushed in, and it's all coordinated by the computer. When the material reaches a certain melt point, it is then pressed into that mold. Okay, so there's our wax pattern. This is the pressed unit. And then you do one of two things. It comes in basic shades, A1, A2, A3, A4. So you can just, if the patient's shade is a perfect A2, you just stain the occlusal anatomy and you glaze it and you're done. Sometimes patient is a little bit A2, but they have a little bit of B2, or whatever the characterization is. So you can actually cut back the facial aspect of the pressed ceramic. So it gets a little complicated because the crown on the right-hand side pops out of the machine, but then you can drill back a quarter millimeter, half a millimeter, whatever the technician feels is necessary to achieve the required shade. Then you put it back into the oven with the same material, the same feldspathic porcelain that you've used for your metal ceramic crowns for years. You then color that and get the shade, the appropriate color. And I've done some color research. Color is very difficult because every one of us has a different perception of color, where it is in the mouth, the type of lighting that's used. So debates about color can get very, very heated. And now with technology, they have machines that can derive the shade of the tooth. But again, should the tooth shade be taken when the tooth's wet or dry? What do you think? C, wet, okay, because if the tooth dehydrates and you don't realize that, and the patient's mouth's been open for half an hour while you're prepping a tooth, and now you go ahead and make the shade, you may have an incorrect shade. So it should be moist. So here's how sometimes you can take the crown and cut back some mamelons and really characterize it, and you can make a perfect match. The first time in my career I was a general dentist. I forgot to touch on that. Half of my career, I was a general dentist, and then I went back and did prosthodontic training. So for the other half of the year, I'm a prosthodontist in academic setting about half the time, and in private practice about half the time. But this is where the artistry of dentistry comes in. And some of you may be very good with color. Dr. Grizzlia knows that the color is my least favorite thing. I'm not very good at it, but a lot of times with prosthodontist, you don't have to, because you're doing all the teeth, and the teeth are going to be all one color. So I have great respect and admiration for anyone who has the eye to match one single tooth to another, because I find that that's where overtreatment occurs. So if someone needs one single crown or one single laminate, trying to get that to exactly match the adjacent tooth is very challenging. So here's our crown. This is what it looks like internally and externally. We can see the core material. Some aspects of the facial has been cut back and characterized. And then we go ahead and find that we can bond it in. So M-Press 1 requires bonding, okay? So you cannot, by prescription, ask for an M-Press pressed ceramic crown and then use ZOP or polycarboxylate or glass ionomer. You cannot do it, the crown will break, okay? So this material requires bonding, but it's versatile. It's got a minimum thickness of 0.7 to 2 millimeters, depending on if you're in an occlusal area, posterior. It's translucent and it's minimally abrasive. The characterization requires cutback. So this is where some people get nervous, because I told you that all these ceramic materials are brittle. So if we take a rotary instrument to a crown and drill away part of it, we're introducing many different micro cracks in that structure. But usually it's the facial. So we're cutting back some aspect of the facial, which is not the occluding surface. But remember, a crown under load, a patient bites into a hard roll, etc., it's very dynamic. So we want the cracks to heal. And when you apply the feldspathic porcelain on top of the core of pressed ceramic, when the heat comes up, you can cure the crack, so to speak. Okay? So you're essentially remelting new porcelain and healing where the crack is. And the reason we know about these old crack phenomena is from an old all ceramic material where the clinician who was principally involved in it was a prosthodontist in Boston. He was using ZOP to cement this particular crown called Dicor, and when a resin cement came out, it was a new cement, he started using the resin cement, and he found out that he had a much higher success rate of these posterior restorations, and it was kind of by accident that that happened. And then when they analyzed it, they realized that some of the flaws in the ceramic were being healed, so to speak, by the resin infiltrating the ceramic. And there's significant clinical data on Empress. It's been around a long time, and the initial studies are out of Switzerland, where they're very precise, exacting, clinicians, and they weren't content to let this become commercially viable until they had the data. And I respect the company for proceeding in that manner. And there's contraindications. So, Dr. Malamet is the prosthodontist in Boston who's analyzed in his private practice. He keeps impeccable records of what type of crown, when did he put it in, what kind of cement, what was underneath it, was it a core, was it dentin, was it gold? And what he found was when you did the internal etching, you had the issue of the ceramic being strengthened by the resin infiltration. The tooth position, he knew that the second molars did not have a good survival rate there. Was it male or female? He found a gender bias. Maybe men have, generate higher occlusal forces. There are more failures in men than in women, and age as well. What else do we know about mean survival life of these types of restorations? So there's a couple of different papers here in two accepted journals that are pretty much clinical journals. They're not pure research journals, but the International Journal of Prosthodontics and Quintessence International. Look at the number here. We're talking about 11 year. And what you find here is interesting. So in the blue, you see at 37 months where are the fractures. And where the molars start to break down is after the initial 37 months. So at 94 months, we can look here and we can really appreciate that for this particular system, the molar has almost doubled in the failure rate. And then this ties into what's a reasonable expectation for the longevity of a crown. So the United States, it's something that was empirically derived. It's not anything that anybody ever studied, and it's simply based on commercial dental insurance. So Mrs. Jones works for Company A, and she had a crown placed in 2000, and in 2004 it broke and needed a new one. Well, guess what? The insurance company will not reimburse the patient for that crown. Whereas if that crown broke in 2006, they will then give a benefit for the patient to get reimbursed for the crown. So they came up with a number, and the number is 5. So I think most of us would feel that, gee, a crown I do should last 5 years. It's a large investment of time and money. But in the United States, that's a parameter that I kind of quote because insurance companies are neither my friend nor your friend. They're for profit. But if they're going to pay for a procedure, then 5 years, if you make a crown, you should understand that it should last a minimum of 5 years. Okay, so if that's the low end of things, what's the high end of things? And there's been many studies of longevity of single crowns, but they get confusing because are they metal ceramic? Are they feldspathic porcelain jackets? Are they all ceramic? And this is where it ties into your database. You have to select what's best for your patient. And that's what I'm trying to provide you today is some indications and some contraindications of where, when, and why. So, margination of all ceramic bondable restorations. You saw this tooth fractured earlier. So, as I tried to point out, this particular restoration is pretty much supragingival. That for me is a positive prognosticator. I'm not down at the gingiva where I've got to worry about gingival fluid contamination of any kind of bonding procedure. So for me, a subgingival restoration that needs to be bonded is not an all-ceramic restoration. It needs conventional cementation, etc. You cannot keep that field from being contaminated. What else? What's a positive prognosticator? If you look closely where those arrows are, all of the edges, all of the margins of the new restoration are going to be in enamel. And I told you earlier, we bond the best to enamel. An enamel bond is very predictable. You use your acid etch, you paint whatever primer, whatever resin is required, and you use your luting agent, and that bond is going to work. So pressable ceramics are also going to be indicated, and that's what was chosen here. So we had a buccal wall intact. So if you look, it's kind of an onlay. If you got a buccal wall intact here, you can do an all-ceramic bonded onlay predictably. You have margination in enamel, and the rest of the bond is to the dentin. Is it as predictable? No. But we have some long-term studies of using pressable ceramic. And one of the principal features of pressable ceramics is that it's essentially feldspathic porcelain, but it has something else in it. Does anybody know what's in pressable ceramics? So feldspathic porcelain has a bunch of components that when we fire it, it turns into a glass-like substance that looks like a tooth. Pressable ceramics has a miracle component, okay, and it's called lucite. So lucite is a large particle that is a crack deflector. So it's very fascinating because as porcelain starts to degrade, as the crack initiates, it can then run into one of these large chunks of lucite and it deflects. So then the energy of the crack dissipates and then the material doesn't fail. It doesn't fracture. So lucite is an important component of the empress materials or the pressable ceramics. And that's why when you get additional longevity when you bond them into place, okay? But again, not all the all ceramics can be bonded in position. So here's some partial coverage maybe. You have a DO, you have some fractured, you have some need for restoration that's molar. So we talked about supragingival margination. To me, this is a positive prognosticator for periodontal health. Anytime I don't have to compromise that gingival sulcus, I'm not going to. Because anytime I get into that sulcus, I don't know how the gingiva is going to respond. What if the technician just doesn't make the exact emergence profile that had been there earlier? What if the patient now has a plaque trap? Now they have gingival inflammation. Now they have gingivitis. Can we predict that gingivitis is going to proceed to periodontitis? No. But to me, that's a risk factor. If I don't have to go under the tissue, I won't. This, to me, is a positive prognosticator. When we look closely here, we're looking at where the enamel is, okay? So on the right-hand side of the slide, we see what I consider a very fresh dentin. That dentin is very yellow. I don't see any staining. Sometimes you'll remove an old amalgam, and there's black dentin stain. There's sclerotic dentin. I don't know, and no bonding study can tell you, is the bond to that type of dentin the same, better, or worse than a bond to regular dentin. So this type of dentin I call unaffected. It seems to me that it has not been affected by other restorative materials, and I think if you use the bonding procedures and protocols correctly, you're going to get a very good bond to that. And we know that the enamel bond is going to be very good. Patients, kind of love anything that's tooth colored. And to critique this, as we look straight down on the left-hand side of the screen, it looks like it's an acceptable occlusal color. But now when we look from the gingival aspect, to me, getting a pressed ceramic restoration to match perfectly is a little bit of luck, okay? Because sometimes when we use the bonding cements, and there's different aspects of bonding cements, there are tinted cements, there's cleared cements, you can't predict it. So I find that, 70% of the time, or 3/4 of the time, it's acceptable. But about 1/4 of the time, it's not acceptable to me. It just doesn't match. But what I find is that this is where the dentist has a bias. I'm disappointed because when I dropped it into position before I hit it with the light, it looked perfect. But we know that when we then polymerize the eluting agent, it's possible that when the reaction goes on, it's going to make the color usually lighter or darker. What do you think? Yeah, darker, unfortunately. Yeah, if it was lighter, nobody would complain. But as you polymerize the resin, the color attribute looks darker. So if it's darker, you're then going to be able to pick up the contrast. But most patients, this is going to be perfectly acceptable to them. Dr. Kurtz, you're crazy, it looks great. My assistant will say, you didn't like that, it looked fine. But to a high discrimination color, it is not, what you wanted in your mind's eye. So you have to be careful, and you can't make unreasonable patient expectations. You got to tell them, I didn't damage your tooth. We're trying to fix your tooth. Unfortunately, this particular color is slightly off, but I don't think we can get it better without drilling it out and drilling away more tooth, because I know I can get the color perfect if I do a full crown. So partial coverage restorations are much more difficult to achieve. So it takes, more talent to drill a tooth a certain way. When you drill a tooth for a crown, you're removing a tremendous amount of tooth structure. And remember what I told you, is that this tooth, despite the fact that it's an onlay placed in 2000 or 2005, at some point will require re-restoration. So if the patient's, say, 40, and now at 50, they become ill. So systemically, they have medical complications, and they're treated for cardiovascular disease, etc. Some of the medications induce xerostomia. So now we have a patient that the oral biology has changed, and now they have root caries. And a patient that had never had root caries their entire career, that you're looking in their mouth for 20 years, now they get root caries. So you can't predict. Now you have to drill off a restoration that's perfectly fine because you cannot access the interproximal root caries. So what about the fit of these all ceramic systems? And essentially, we judge most of them by the gold standard, which is not a gold crown, but a metal ceramic crown. So we know we can cast alloy efficiently to many different types of preparation designs. If we look at Procera crowns and Empress crowns and Inceram crowns, where are the distortions? And these are in microns. So if we look, Inceram crowns initially, there's very large discrepancies in the margination. And there's reasons for that. It has to do with how do they develop that particular core, what's the firing cycle. But in the United States, the American Dental Association, the clinical acceptability for a crown is 100 microns. So you can actually make a crown with a fairly significant gap that, in theory, will be filled in by the eluting agent, and it's perfectly ethical and acceptable to cement that restoration. And that was delineated a long time ago because 100 microns is the tip of a new U3D Explorer. So that if you can't get that in at the margin, in theory, the crown is sealed. And this, again, is an exacting study from the International Journal of Prosthodontics, where this is not in vivo. This is just they fabricate crowns, and they're examining how well do they fit on dies. The topic we're going to talk about now are these machine ceramics. And remember, some of these machines are in laboratories, and some of the machines are in dentist offices. Okay, so some of them are ideal for making single tooth restorations, and some of them have been used in a laboratory to make multiple unit restorations. So essentially, the one system that most people are aware at that gets promoted the most is the CEREC system. And they have a wide variety of materials that can be used in the machine. The technology is there. You have a situation where you're no longer making an intraoral impression with any kind of elastomeric material. Again, elastomeric material, if someone's a gagger, that's a huge battle. And then it's the ethics of the dentist. You miss the impression, patient's gagging, now you got to make another impression. When you take away the physical impression out of the patient's mouth, there are advantages to doing a digital impression, which means you take a TV camera, you put it in the mouth, and you take a picture. That then develops in the machine and has a very accurate depiction of how you have drilled and prepared that tooth. Then the machine can recognize the margination with your assistance when you outline it. It's almost like a video game, Etch-a-Sketch. You go around the margins, And then the machine then goes ahead and uses feldspathic, straight feldspathic, porcelain, veneered on pressed ceramic, or composite. There's different materials that then can be machined to the shape that you want. So advantages are, CEREC can be same visit. It does take some time, so if the patient comes in at 9 o'clock and you make the digital impression, the advantage is they can then wait in the waiting room, read something, the machine makes the restoration, you can see another patient. The advantage is that you don't have to make a provisional. So downtime is that you don't have a provisional, and the other positive thing is that you're not paying the technician to make it. You're paying the manufacturer. So it's ease of convenience. Some dentists have patients whose time is very problematic. One of the things in prosthodontics that becomes a major problem is called maintenance of prostheses. So as a prosthodontist, the thing that frustrates me the most when I'm teaching is when a student doesn't understand, there's not enough retention and resistance form, and the provisional falls out. So their answer is always the same. They don't examine that. Their solution is always a stronger luting agent. So they put something in with a provisional cement, it's not working, they'll use a final cement on the provisional. And then a week later, the patient's frustrated, they come back in, guess what? It came out because they did not develop the appropriate retention form and resistance form, and that's why the luting agent fails. It's the same thing you'll have it in your career. If the provisional crown is not staying on the tooth, it better make you rethink your tooth preparation and your material selection. So what I find with CEREC, and I do not have a unit, it's versatile and it's certainly appropriate, but I find that if you have a very high demand patient, there's limited aesthetics, which the company is addressing. They're trying to come up with formulations where they can make it easy for the dentist to stain, glaze, change the colors. But the problem with a lot of these aesthetic applications is that long term, how long is that going to last in the patient's mouth? So surface staining does not have the integral beauty of something that's been fired. So if you surface stain a crown, it's going to look great today, but in 1 or 2 years, it may be unacceptable to the patient. So the preps are same, as the pressed. It has varying wear characteristics that are not well known because it depends on the width of the restoration. So if something's not going far up a cusp and it's not being subjected to a lot of lateral movement of mastication, that's going to have a different type of wear than something that's a larger restoration. And there is some good data available. The manufacturer has some 10-year prospective data where they examine what type of luting agents are used and the success rate, and it is 10-year data. So I mean, these are systems that only get better. And believe me, this generation of dentists that's out there, you will no longer be using in your career material in the mouth. I'm convinced of that. It's going to get to the point where you're going to have everyone's going to have some kind of imager that's going to image the tooth after you prepare it, and then either you send that off-site or you have in your office something that's going to make the restoration. So aluminous oxide, we've touched on. It was another one of those high-strength core materials that showed a lot of initial promise, but is starting to fade a little bit from the marketplace. Some of them that we see and we know are known commercially as Procera and Inceram. Procera is something that is very prominent in the marketplace, has higher strength than the other types of ceramic that we've talked about, the feldspathic and the pressed ceramic. It's pretty much limited to full coverage because of the exacting ways that it's made. It's very hard to make small restorations with it. It can be a CAD CAM, it can be a computer-aided design and a computer-aided machine core. So you can take your conventional die, you can image it, and you can email that to the technician. The technician can then make the coping and send it back to you. And this is the technology. I mean, this is what you guys are all about. The future of dentistry is sitting in front of me. And what you guys are going to be all about is this type of stuff, is that machine can give you an exact scale replica of your die, the way you drill the tooth, whatever way you drilled it, be it a butt joint, whether you did a chamfer, whatever your preparation is. They have a very sophisticated formula that will, the way we do, we have to generate space on every indirect restoration for what? Anybody know? Why do we need space? If something's too tight and fits too good, there's no room for what? Cement, exactly, okay? So if you machine something to the tolerance of 10 microns, that's terrific. But what's the minimal film thickness of a eluting agent? Anybody know? 40, yeah, 25 microns, okay? So if you look at glass ionomer or zinc oxyphosphate, the way we measure this is prosthodontists, the dental material scientists, love to measure things. So it's a very simple experiment designed many years ago. You take 2 glass slabs and you put the eluting agent on it, and then you measure how far apart are they. Now, is a glass slab a crown? No, but it gives us some information. So if you have something that's very well made with minimal gapping, 10 micron gapping, when you put that eluting agent in and you cement that restoration, it's going to be what? High. Okay, so the computer program knows that it has to account for space. And whoever invented these protocols is a genius, because ceramic milling and compensating for shrinkage and distortion is a fascinating subject for anybody. The point is that the old technology is that when we have a die, a stone die, anybody know what we do to the stone die to make the space? Dye spacer, exactly. So we're going to paint on some dye spacer. Do the ladies know what dye spacer is? Nail polish, yes. Okay, so if you go and buy nail polish, it's $1. But if you buy dental dye spacer, it's how much? Yeah, 200% more, it's $20. Okay, so it's essentially you're trying to space out what happens. It's also, you should know, the laboratory is going to make a model or a cast from your impression if you're not pouring the cast yourself. So there's significance to the colors of what? The stone. So some stones have what? High expansion. Some stones have low expansion. And if you don't understand that, it's going to play into the space that you have in the crown. So if the technician, if you find that you're having trouble seating crowns and they're using a no expansion stone, even though they space it, you may want to consider telling the technician, gee, why don't we try some high expansion stone? Also, in metal ceramic technology, you can compensate if you want more expansion of a crown. The technician knows that you can alter the powder-liquid ratio, essentially, of the investment. Okay, so there's many different ways to generate this space. The fact is that this is the way of the future. And again, it's like a video game. So here's the way the computer is mapping out many points of the scan of your die of how you prepared the tooth. Then you go ahead and you just outline, where do I want this crown to end? So it's three-dimensional, it's fascinating. If you ever go to a dental meeting and they have this type of technology, play with it, because you can turn the die upside down, left to right, you can import whatever amount of spacing you want, etc. So it is absolutely the way of the future. So philosophically, with the luminous oxide, something like Empress can be made in one giant chunk. So just like a full gold crown. A full gold crown is what's called monoblock. Is only one material. An Empress crown is one material. Luminous oxide has to be two materials, okay? Because it has a core that is very white. It's unacceptable aesthetically. They can't develop it presently to make it look aesthetic. So you can't make the crown out of one material. You have to veneer it with the old soldier feldspathic porcelain. So that's called a biphasic system. So anytime in dentistry we start running into more than one phase, we can run into complications. Because things that are made in one piece, in my opinion, seem to resist long-term fatigue failure better than things that have two materials, okay? And it gets very complicated because, as I said, we don't really know enough about these all-ceramic systems because a lot of them haven't been around for 5 years. Because 5 years seems to be the point where you can start to delineate problems. So here's a study of Procera crowns, mean service life, and once again, we're seeing the same kind of data. Despite the fact that you have more advanced technology, you're seeing the same failures pretty much in the same group, but at a lesser number, granted. So after 5 years, 92 of 100 crowns are going to be in the patient's mouth, but 8 of them have failed. And the problem with some of these failures is these are called catastrophic failures. But some failures are subtle and only the dentist knows. Mrs. Jones comes in and now you're looking in their mouth and the mesial buccal cusp of number 14 is absolutely chipped. Because when you put that crown in, you know it wasn't. Then the patient comes in, a year later, and you see that because it was chipped, you should have done something. So if you notice a chip on a crown you placed, simply, it's rough, polish it. Because the rough surface is an ingress area for liquids. And liquids in ceramic, there's a pumping action that contributes to the fatigue loss of the material. And then sometimes the patient won't notice it. They only notice it when it's right in the front, they have a chip, or if it's rough to their tongue. So when you do your examinations and you're trying a new all ceramic material, in my opinion, as a conscientious, ethical clinician, you should follow that, very closely. With these aluminous oxides restorations, we got higher strength, but as we said, they're limited to full coverage, the CAD/CAM core. The core is opaque. There's no shades available. That's why you have to veneer it with the other material. But you do have more predictable margins, okay? So a margin generated by a machine on a very specific computer protocol is going to give you a predictable margination. And as we saw earlier, there are specific consistent follow-up with Procera all ceramic crowns. So there's advantages of an aluminous oxide crown, okay? Because some of us know that when you prep into some teeth, so has anyone ever seen tetracycline stained teeth? Do we know what that is? So patients, when you drill into that tetracycline stained tooth, does it get lighter or darker as you drill into the tooth? Anybody know? Yeah, darker. So it gets darker. So an opaque core can mask some of that very dark color of the tooth, whereas an Empress material, which is translucent, that's going to definitely show up when you lute the crown into position. So aluminous oxide crowns, essentially you can't tell one from the other. And then last but not least, the zirconia-based ceramics. These are known commercially as lava, zircon. Procera now makes zirconia. And zirconia is the buzzword. And again, do the women know about zirconia? Would you rather have a diamond ring or a zirconia ring? The important takeaway message here is zirconia-based ceramics are the new ones. They're the highest strength of any dental ceramic. It's kind of like aluminous oxide. It has a core that has to be veneered, and pretty much it's indicated is full coverage. So we're talking about, when I say full coverage, it's a full crown. So you can't really do partial coverage. And as I said, partial coverage is, to me, something that is an advantage to the patient. And that's, be it gold or any kind of all ceramic, is that partial coverage usually means that you're cutting less tooth, and usually you're not violating the gingival aspects of that tooth. Core is opaque, but it's available now in shades. So they're starting to, like any new novel material, they've made the material, and now the dentists are asking for improvements in it, and the manufacturers are responding. Unfortunately, there's limited clinical data, and the limited clinical data we have, there's poor FPD performance. So Irina Saylor is a prosthodontist in Switzerland who's very ethical and has conducted a number of these investigations, and unfortunately she's presented these at some research meetings, and we know that the fixed partial denture aspects presently of zirconia is lacking. So why no all porcelain crowns on molars? Well, because anecdotally, I see this type of problem occurring, all right? So the restoration looks beautiful, but if we look on the right-hand side, we see a total debonding of the facial aspect of the material. So is that a luting problem, or is that just an occlusal problem, or is that something that maybe I wouldn't have selected that, okay? If you look on the crown on the left here, same thing. You see an interesting fracture of both the veneering material and the, so in other words, it didn't just chip the veneering material. This is a fracture of the core. So right in here, that's all core and veneering material gone. Same thing here. That's just a halo-type fracture, which has been noted in the literature previously. So I'm reluctant, unless someone's an actress or someone has a high aesthetic job position where they don't want to show any type of metal or any thread of metal. And that's where, if you really feel strongly, you can do a metal ceramic crown where you have a butt joint in porcelain on the facial aspect. So there are alternatives to ceramics, and that's how we're going to kind of conclude. So we talked about, hopefully acquainted with you. I don't expect you to be an expert in all ceramic materials, but it should give you some foundation knowledge, and if you're really interested in this, you should ask your professors, you know, do they use them, when do they use them, because everyone has a bias. So the alternatives to ceramics for me are, in my own mouth, if I fracture a tooth that's had an MO amalgam with a buccal pit in it for 25 years, I'm going to decide that I'm going to prepare the tooth, and I'm going to place a, you can place an all-ceramic restoration here. Going back, if you look closely, we talked about margination before. This is all enamel. If you look at that box, the proximal box, unfortunately this thing's not moving well, this is all enamel. And then if you see here, this is the thing I was talking about. If you look closely, unfortunately I don't know if you can see it, right in this area here, there's some staining, there's affected dentin from the previous amalgam restoration. So I don't know that that's going to bond 100%. What I do know is that I've got enamel all the way around, and this is where I will do an all-ceramic restoration on a molar if the patient insists or has requested it. And they come very nice, and like I said, if you look here, there's always that mismatch between the buccal, not always, but 70% of the time, and the look. Then there's indirect composites. So you make an impression, and then there's different materials that you can use, but they're composite resin materials that require exacting bonding protocols. And there's different materials that have to be used to activate the composite prior to bonding in it. So they're known as sculpture, Targus. They've kind of fallen out of favor in the last few years because the all-ceramic materials have greatly improved. They're less brittle and less abrasive than ceramic. They're better contours than a direct restoration. So if someone comes in and they need an MO restoration on a maxillary first bicuspid, high demand patient aesthetically, I find that it's simpler for me to do this type of material, an indirect composite. So I make an impression, I send it to the laboratory, and I get my indirect composite restoration, and then I monitor the color and the margin over time because it changes. The same preparations as previously. At the time, they had 4-year data that's favorable. There's more data showing favorable 5-year data on these type of restorations. So if you look, again, you have, I always ask a patient, gee, how long have you had that filling? And if they can't recall, it usually means it's more than 5 or 10 years. So always check longevity of restorations in the patients that you're treating. So you can go ahead and start removing the amalgam and preparing the tooth, but you can start to see you've got positive prognosticators, supragingival, but back here, you're violating the gingiva, okay? So once you start to do that, you may want to think about this type of restoration. So I still do, in my mouth, I have gold restorations. I also have indirect composite. I also have metal ceramic, so I'm a walking in vivo experiment. But if you look, this type of crown is not approximating the gingiva on the palatal aspect, okay? And it's essentially an onlay, 3/4 crown, 7/8 crown, and you have to go into proximal. You have to go near the gingiva into proximally because usually there's a pre-existing restoration. So anyone that has previously a box cut for an MO or a DO or an MOD, you're going to wind up compromising that gingiva. So cast gold is still a viable alternative. I don't know if it's still in the curriculum here, but it's certainly something that most laboratory technicians know about. You need minimal tooth preparation, so 0.5 millimeters. You can use it for inlays, onlays, crowns, and fixed partial dentures. It's got reliable lab technology. Most technicians are very comfortable with this. Gold margins, they say, are better because you can do something with a gold margin that you can't do with a ceramic margin because of the ductility of gold alloy. After you cement it, you can burnish that alloy and bring down the margin, almost imperceptible with the tooth structure. So if you ever see a gold onlay that's been in a patient's mouth for 20 years, close your eyes and drag your Explorer between the tooth and the restoration. And it's fascinating. You can't really detect it. By the older clinicians who did this routinely and learned this, they were experts in this, and they're fascinating restorations to admire. You have favorable, plentiful long-term data as well. So if the patient is dissatisfied with aesthetics of metal ceramic restorations, I don't know if you can see that, but sometimes very demanding patients, maybe they don't like the hint of a little bit of metal up at the gingiva. They have a high smile, they have a high profile job, whoever, who knows what their complaint is, but you have to start thinking about something else. So what we also have to talk about is that metal ceramic can look equivalent to all ceramic. So this is in somebody's mouth. There's some Procera crowns, there's some veneers, and there's metal ceramic. And essentially, an untrained eye can probably not pick out any of the differences there. And metal ceramic, for me, is a standard of care for crown FPDs. On a rare occasion, when I have to, because of a particular aesthetic demand or aesthetic concern, I will go to one of the all-ceramic alternatives. They claim poor optical properties than all ceramic. That's fairly limited, though. It has favorable, plentiful long-term data on making metal ceramic crowns. And once again, this is Dr. Goodacre, prosthodontist and dean of the dental school in Loma Linda in California. He tells us this. He's done a retrospective of metal ceramic restorations and finds very favorable outcomes. So clinical treatment for all ceramic, what's required? Lots of stuff. Sometimes when it's desperation time and I have to use all ceramic, a conventional custom cast abutment and cementable all ceramic crown. It's not always a winning combination. So when you don't plan things or you get healing that's not 100% favorable, you have a situation here in a high smile patient. An implant was placed, the implant is integrated, except that the healing abutment is not even on there, that's the sealing screw, and the platform of the implant is equivalent to what? The gingival height of the crown. So we go ahead and order a conventional cement-on abutment and get an all-ceramic crown, but you have unacceptable aesthetics. There's an all-ceramic cementable crown, but you still see what? You still see this, it's a required necessity. When you cast up a custom abutment for an implant crown, there's a piece of metal that's there. Now, if this implant was 3 millimeters deep, we wouldn't be having this conversation. The fact is, it's at the crest of the gingiva, and it's a ceramic failure. It's an aesthetic failure. But again, with new technology, we have to retreat. And retreatments are the bane of any graduate program. If there's a retreat, we got to know there was a failure of the system. Either the faculty or the laboratory technician made an error, and the error cost the patient time. They have to have a retreatment, and it costs the institution time because somebody's got to pay for the new parts for the implants and pay the technician to make the new restoration. So here's a situation where you can have an all ceramic, screw retained, zirconium crown, and it goes direct to the implant. And for this patient, she was very pleased the fact that when she smiled, she did not have this metal band. So take-home message. All right. There's no single solution. There's many different approaches to find the solution for that particular patient. So it's prescriptive treatment. You have to have your knowledge base to select the crown or the restoration that's best for that particular patient. So veneers, feldspathic and pressed, I think they're fairly predictable, especially if the margination is all enamel. Any type of anterior all ceramic. Any of them pretty much will work. I'm not really concerned maybe on a cuspid and a heavy bruxer, but for the most part, anterior all ceramic is going to work. You have fairly decent validity for any type of pressed alumina or zirconium or milled premolar restorations. Molars, I'm still more comfortable using metal ceramic or full cast crowns, onlays, when they're not in the aesthetic zone. Then FPDs, still the most predictable is metal ceramic or full cast. So decision making is complicated. There's patient desires, there's advertisements, there's peer pressure because some of your colleagues are doing all ceramic, you don't want to be the one that's not. There's costs, there's return on investment. So as a dentist, you're a small business owner. And when you invest in yourself, there's no better investment. So people are here, you're getting an education, that education should help you in your private practice of dentistry make good business choices. So you have to also balance on the left-hand side, you know, what's going on with the patient and then what's going on with the clinician. So what's the clinical evidence to do that crown or do that onlay? What's the clinician's personal experience? And most importantly, what's the education? So as a dentist, you're a lifetime learner. So when you graduate from any dental school in the world, as far as I'm concerned, you have an ethical obligation to continue your education, attend seminars, read books, read journals, because your patients deserve that. And I'd like to thank Dr. Estefan. He's a colleague of mine at NYU, and he did most of the preparation for this lecture. And then these are my hospital students. As prosthodontists, sometimes people feel they're very rigid and stiff, but we know how to have fun. And I invite anybody to come to any of the prosthodontic meetings in the United States. In particular, we have one in New York every year in early December, which is not favorable for the climate. Or the American College of Prosthodontists has a website and an annual session every year, and it's a great place to learn what is new in the prosthodontic specialty. Just like if you do orthodontics as a general dentist and you want to do some orthodontics, I would tell you to attend, you know, a specialty group meeting of orthodontists. Okay? Thank you very much. Muchas gracias for your attention.